Step 2, CK Neurology. We're doing a miscellaneous CNS cleanup and running through the decision logic. Let's get right into it.
Section 1. Post-exposure neurologic sorting.
Let's start by mapping out some high-yield vignettes so you can instantly recognize these on exam day. If a patient comes back from a hiking trip with ascending weakness, think tick paralysis. What about blunt head trauma followed by a battle sign or raccoon eyes? That points straight to a basilar skull fracture. Now, if you see clear nasal drainage after an injury, we're talking about CSF rhinorrhea. If a postpartum patient or someone taking oral contraceptives suddenly develops a severe headache with papilledema, that's a huge red flag for cerebral venous sinus thrombosis. And finally, a mild traumatic brain injury followed by headache and amnesia is your classic presentation for a concussion.
Section 2. Normal aging versus tick paralysis. First up, separating normal physiologic changes from actual pathology. Finding distal vibratory loss and reduced ankle reflexes can actually just represent normal aging. You might also notice a slower pupillary response to light, presbyopia, hearing loss, or even a broader-based gait with a shorter stride. The key here? These are strictly considered normal age-related changes only when the patient's daily functioning and the rest of the neurologic exam are completely intact and reassuring.
Now, let's contrast that with something acute, like tick paralysis. This presents with a rapidly progressive ascending weakness that happens fast, over hours to days. There's no fever, no sensory loss, and critically, a completely normal CSF exam. This is a major testile mimic for Guillain-Barré syndrome. But remember that Guillain-Barré is usually more symmetric, slightly less abrupt in onset, frequently features autonomic instability, and classically shows elevated protein without elevated white blood cells in the CSF.
So what's the mechanism? An attached tick is continually releasing a neurotoxin. That means your immediate next step in management is a meticulous physical search and removal of the tick. The good news is, simply taking the tick off results in spontaneous and rapid improvement for most patients.
Section 3. Head trauma and skull fractures.
Moving on to traumatic injuries. If you spot raccoon eyes or a battle sign, which is ecchymosis right over the mastoid, you are looking at a basilar skull fracture. These fractures can also present with hemotympanum, CSF otorrhea, or CSF rhinorrhea. Here is a massive contraindication to remember for the boards. You must strictly avoid placing a nasogastric tube. Why? Because there's a very high risk you could inadvertently push that tube right through the fractured cribriform plate and into the cranial vault.
When do you order a head CT without contrast for an adult? The indications include age 65 or older, having a coagulopathy, being intoxicated, or experiencing a dangerous mechanism of injury. You'll also want to image for high-risk symptoms. We're talking a Glasgow Coma scale under 15, vomiting twice or more, seizures, severe headache, or any focal deficits. Now, for children with bleeding disorders like hemophilia who sustain head trauma, the decision logic changes slightly. You need to order that non-contrast CT, but you also have to replace the deficient factor immediately.
Going back to clear positional drainage after skull trauma, that heavily suggests a skull base leak, which often presents as unilateral watery rhinorrhea. To confirm the diagnosis, you test for CSF-specific proteins, specifically beta-2 transferrin. Your initial first-line management requires strict bed rest, elevating the head of the bed, and avoiding any straining. If the leak is persistent, you escalate to placing a lumbar drain or going in for direct surgical repair.
Section 4, Concussion and Post-Concussion Syndrome. Let's look at mild traumatic brain injuries. By definition, a concussion involves absolutely no structural injury. The management logic here is all about a strict, gradual return to activity. It starts immediately with same-day play restriction and a mandatory brief rest of at least 24 hours. After that, patients progress step-by-step through light aerobic exercise, then non-contact sports, and finally back to full contact sports. But they only advance if their symptoms do not worsen at any stage. You also need to enforce initial neurocognitive rest, which means limiting screen time and getting specific school accommodations.
Now, if those cognitive symptoms and headaches persist beyond 4 weeks, the diagnosis changes to post-concussion syndrome. Keep in mind, risk factors for this include non-adherence to that strict return-to-play protocol we just talked about or a history of multiple prior concussions. At this stage, your management strategy shifts purely to symptomatic relief and returning the patient to activity as they can tolerate it.
Section 5, Venous Sinus Thrombosis. Shifting gears to vascular emergencies. If you have a postpartum patient or a patient taking oral contraceptives who suddenly presents with a severe headache and papilledema, that should instantly trigger your suspicion for a cerebral venous sinus thrombosis.
Other risk factors to look out for are known thrombophilias, malignancy, or localized head and neck infections. The clinical features you'll see are all driven by increased intracranial pressure. So, think severe headache, vomiting, seizures, encephalopathy, or focal neurologic deficits. For imaging, you have a choice. You can go with MR venography for the absolute highest sensitivity, or you can opt for CT venography if you need an answer faster. Sure, an elevated D-dimer supports your clinical suspicion, but you absolutely need dedicated venography to confirm this diagnosis. For definitive acute treatment, you start systemic anticoagulation with either unfractionated heparin or low molecular weight heparin. This stops the clot from propagating further, and yes, you use it even if there is potential hemorrhagic transformation.
Section 6. Neuropathies and TBI complications.
Let's wrap up with a few specific high-yield complications. First, cavernous sinus thrombosis. This usually follows a facial or sinus infection and presents with intense eye pain, chemosis, proptosis, and diplopia. The classic exam clue is ophthalmoplegia involving cranial nerves 3, 4, V1, V2, and 6. Because of the venous connections between the sinuses, these symptoms can actually progress incredibly fast from unilateral to bilateral.
Next is distal symmetric polyneuropathy. The key localization clue here is a length-dependent, stocking glove sensory loss, but with relatively preserved motor strength. The sensory symptoms almost always start all the way down in the toes and feet before slowly moving proximally up the limbs. And finally, paroxysmal sympathetic hyperactivity. This occurs following a severe traumatic brain injury. You'll recognize it by these intense episodic autonomic storms. The patient will suddenly have massive spikes in heart rate, hypertension, tachypnea, fever, diaphoresis, and posturing. It's triggered by a disruption of autonomic regulation in the brain. The critical decision logic here is making sure you differentiate these autonomic storms from infectious complications or newly evolving intracranial hemorrhage.